All right, let's set the scene. Imagine you're a medical resident, fresh on the hospital wards, and you're about to present a really fascinating case to your attending physician. Today, we're going to break down one of the most common, yet honestly wonderfully complex presentations you'll see in internal medicine, the pleural effusion. By the time we're done here, you're going to know exactly how to take this all the way from the bedside physical exam right down to the nitty-gritty of diagnosing the fluid itself. So, we start right at the bedside with our hook, setting the stakes for a patient who is suddenly short of breath just walking across the room. We've got a 64-year-old guy who comes in with 6 days of fever, chills, and coughing up this rusty sputum. And for the last 2 days, he's been having this sharp right-sided chest pain that just gets worse every single time he takes a breath. Now, what's equally crucial here are the negatives. No leg swelling, and he sleeps totally flat without any issues. Hold on to this clinical picture, guys, because literally every single decision we make from here on out traces right back to this exact bedside story. But before we go full detective on our 64-year-old patient, we really need to define the exact problem. What is a pleural effusion? Well, normally, you've only got a few milliliters of fluid in the pleural space. It basically acts as this super thin, lubricating film so your lung can glide smoothly against the chest wall when you breathe. But in this case, the plumbing is backed up. An effusion is simply excess fluid pooling in that space. It happens when the formation of fluid outpaces its absorption. Simply put, either the body's making way too much fluid, or it's just clearing out way too little. Now, when we examine him, we find what we like to call the classic bedside fingerprint. This is a physical exam triad that almost always travels together, and it tells us that fluid is layering right beneath that lung. If you tap on his right lung base, you're going to hear dullness to percussion. Listen with your stethoscope, and the breath sounds are distinctly decreased because all that air movement, it's muffled by a layer of liquid. And finally, reduced tactile fremitus. This means when the patient speaks, the vibrations just don't travel well to your hands, since fluid transmits sound pretty poorly compared to a nice aerated lung. Okay, so when you're rounding with your attending, you've got to prove exactly why you're considering cardiac causes alongside infections. Looking at the big picture, roughly 1.5 million cases a year in the US. About 40% of these are driven by congestive heart failure. Another 25% are parapneumonic, meaning they're tied to an infection, like pneumonia. Then you've got 15% caused by malignancies, and about 10% from pulmonary embolisms. Remember, an effusion is just a sign. It is not a final diagnosis. Our main job as clinicians here is to hunt down and name that underlying cause. And this is where the pathophysiology gets really elegant, because it splits the entire concept of effusions into 2 distinct buckets, a systemic plumbing issue versus a local inflamed leak. Literally every single effusion sorts into one of these 2 camps. A transudate is your systemic pressure problem. Fluid is being pushed across a perfectly intact membrane. An exudate, on the other hand, is a local issue. The membrane itself is inflamed and leaky, or maybe the lymphatic drainage is blocked, which basically leaves the door wide open for proteins and cells to just pour right in. So, transudates, the systemic problem. Congestive heart failure is the classic example here, driving 40% of all cases. It functions as a pure pressure problem, forcing clear fluid right across a completely intact membrane. And then we have exudates, the local leak. On the flip side of things, parapneumonic infections, which is exactly what we suspect in our patient, create local lung inflammation. That makes the membrane leaky, allowing all those proteins and cells to rush in. So, how do we figure out which bucket our patient is actually in? Well, we perform a thoracentesis. This is the defining diagnostic test, where we use a needle to draw that fluid right out. The golden rule on the wards is to tap any new effusion that's greater than 1 centimeter thick on an ultrasound or a decubitus chest x-ray. It's an incredibly safe procedure when done with ultrasound guidance by someone who knows what they're doing. And listen, this is key. If you suspect a parapneumonic effusion, just like we do with our feverish coughing patient, you do not delay. You absolutely cannot rule out an infection just by staring at a chest film. Passing lights criteria. Once we have that fluid, we send it straight to the lab to face the ultimate security checkpoint. This objectively proves whether we're dealing with a systemic transudate or localized exudate by analyzing the protein and LDH. Now, the absolutely crucial point to remember here is that if the fluid meets even one of these 3 mathematical rules, it is instantly branded as an exudate. It's pretty straightforward. If the ratio of fluid protein to serum protein is greater than 0.5, it's an exudate. If the ratio of fluid LDH to serum LDH is greater than 0.6, boom, exudate. Or if the fluid LDH level all by itself is greater than 2/3 the upper limit of normal for serum, you guessed it, exudate. Any single positive test knocks it into the exudate bucket. You need all 3 to be negative to call it a transudate. So what did our 64-year-old patient's fluid actually reveal? The lab results are finally back, and it's time to see how his fluid held up against the criteria. We already know he came in with a fever, that rusty sputum, and pleuritic pain. We strongly suspect an infection, right? But in medicine, we rely on the hard data to guide our management. Let's look at the numbers. All right, this is that awesome moment on rounds where the clinical picture becomes crystal clear. With the fluid protein ratio of 0.7 and an LDH ratio of 0.8, Light's criteria instantly flags us as an exudate that is just packed with neutrophils and bacteria. I mean, both of those ratios blow right past our 0.5 and 0.6 thresholds. Plus, the fluid itself actually looked cloudy to the naked eye. The cell count showed a heavy predominance of neutrophils. Those are the white blood cells that fight acute bacterial infections. And to top it all off, the gram stain confirmed our worst suspicions, gram-positive cocci. We also have to check the fluid's pH, and at 7.05, it drops well below that critical 7.2 threshold. This carries huge weight for our next steps. Think about it. A normal pleural fluid pH is quite alkaline, hovering around 7.6. But when bacteria are actively metabolizing and producing acid inside a closed, restricted space, the pH just plummets. Seeing anything below 7.2 tells us right away that this is a highly hostile, deeply infected environment, and the patient's body simply cannot clear it on its own. We also see that the glucose is dramatically low, sitting at just 42 milligrams per deciliter. This further paints a really vivid picture of an aggressive, localized infection that is just burning through resources. When you see glucose drop below 60 in pleural fluid, it literally means the bacteria and the white blood cells are eating up all the local sugar to fuel their battle. So, if we step back and analyze these numbers, we can start recognizing some very distinct clinical patterns. For example, a classic congestive heart failure transudate that would have a normal pH and normal glucose with barely any cells. But our patient's profile, with those high polymorphonuclear cells, the decreased pH, and the tanked glucose, points squarely to a complicated parapneumonic effusion. Now, it isn't quite an empyema yet, which would mean frank, thick pus with tens of thousands of cells and severely rock-bottom pH and glucose, but make no mistake, it is deeply infected. We've officially cracked the case. The patient has a complicated parapneumonic effusion, which basically means the fluid is infected, and it is absolutely not going away on its own. Now, if it were a simple, uncomplicated effusion, say with sterile fluid, normal pH, and normal glucose, we could just give him antibiotics and wait it out. But the word complicated means the bacteria have physically invaded the pleural space. The pH has dropped, the glucose has dropped. And because it's complicated, our management plan requires two definitive immediate steps: giving IV antibiotics to target the pneumonia and placing a chest tube today to drain the space. You simply cannot just give this guy IV antibiotics and send him off to the ward. That infected fluid is essentially acting like an abscess in the pleural space. Antibiotics have a really hard time penetrating that much fluid effectively, so we have to physically drain it out with a chest tube thoracostomy, all while aggressively treating the underlying pneumonia. Okay, before we wrap up rounds, your attending is definitely going to want to know if you're aware of the major can't-miss pitfalls. For instance, you've got to remember that a diuresed CHF patient might actually show a phantom pseudo-exudate. You have to unmask that with cholesterol tests. See, when you give a heart failure patient diuretics, the water leaves the pleural space way faster than the protein. This artificially concentrates the fluid, tricking Light's criteria into calling it an exudate. You can rescue this by checking if the fluid cholesterol is under 55. Also, always remember to tap early so the fluid doesn't organize into a thick, fibrous peel. Never drain more than 1.5 liters at a single time to avoid re-expansion pulmonary edema, and never ever skip ordering the pH and glucose on your lab slip. An effusion is just a sign, right? So if you don't actively hunt down the underlying cause, what else are you missing? The fluid always follows the cause, leaving us to wonder, what other hidden diseases are out there just waiting for the right clinician to connect the clues? As we saw today, the effusion is merely the fingerprint left at the crime scene. It is entirely up to you to take those clues, the history, the physical exam, the fluid analysis, and track down the true culprit. Whether it's a failing heart, a hidden malignancy, or, like in our guy's case, a severe pneumonia. Keep asking questions, keep looking at the data, and please never treat just the symptom. Because if you just drain the fluid without finding the fire that caused it, you really have to ask yourself, how long until that space just fills right back up again?